Welcome to the Voyage Clinics podcast. I'm your host, Dr. John Sanders, family medicine doc. Today, I have Dr. Jeff Hammond with me. He's a podiatrist, and we're going to talk everything, all things foot and ankle, really common things, maybe some less common things, and just kind of dive into that. Our objective is, as always with the Voyage Clinics podcast, just to educate the community and bring life and happiness to everybody. It's pretty groovy.
Yeah, let's have fun. I mean, talk about everything. Warts, blisters, bunions, oh my.
Let's go. Dr. Hammond, nice to meet you and nice to have you on the podcast. Tell us a little bit about your journey, where you're from, give us a little background on your clinic, and let's go from there.
Yeah, so originally from Provo, Utah. Grew up here. I moved down the hall and across the hall, so not very far when I was a kid. Got into sports medicine by crashing in a triathlon, putting holes in my stomach, scraping myself up. And the doctor sewing me up said, come shadow me. And there I was and found out a lot of foot and ankle issues. And so met dating my wife, who's also applying to medical school. And we matched together in Cleveland, Ohio. She did medical school there. I did podiatry school there. We stayed in Cleveland doing a residency there. And then I decided to come back to Utah and I opened up my own practice.
That's really cool.
Yeah.
What kind of doc is your wife?
So my wife's a dermatologist.
Yeah, she's cool.
Yeah, she's good. Yeah.
They're so much cooler than us.
They're geniuses. Yeah. If people don't know what dermatologists are like, they're brilliant.
So tell me about this crash. You said you poked holes everywhere.
Yeah.
Were you like riding a bike and hit a porcupine?
Yeah, basically. No, I was coming down the road. You know, it was after coming down a hill, so going pretty quick, 25, 30 miles an hour. And we went into this big S-turn on a triathlon. And someone came in trying to pass me. You can't cross the middle line on a triathlon. Not necessarily clipped me, but got close enough to spook me. Went to the side of the road, hit gravel. Next thing you know, I'm laying on the ground. My handlebars had banged into my stomach and put holes into it.
Really?
And then, you know, scrapes and bruises everywhere.
Well,
so
yeah,
it was fun.
That's a good injury.
But I finished the race.
And it inspired you to become a doc.
Yeah, and inspired me to become a doc.
That's really cool.
It was great.
Tell us about podiatry as a profession, as a med school kind of talk. Speak to that space.
Yeah. So podiatry is interesting because it doesn't follow the same path as medical school, meaning going to a traditional medical school, whether DO, MD school. There are now actually 11 podiatry schools in the country, but it follows the same model. It's a 4-4-3, meaning 4 years undergraduate, 4 years of podiatry school, medical school, same training, and a 3-year residency. So we do all the same stuff. I did a psych rotation, emergency medicine, but our last 2 years, we really focus on surgery, sports medicine, wound care, and things like that in our residency. But yeah, it was funny. Me and my wife went to the same town, had the same teachers, but different schools.
Cool.
So,
well, let's get into the nitty gritty.
Yeah, let's do it.
Okay. Man, as a family dog, we see all the things, right? All the things.
Yeah.
Some very, very common things that I want to kind of mull over with you. Fungi on the foot. I'm a huge mushroom forager. I'm up in the mountains every weekend looking for mushrooms and stuff. And
brave soul.
Unfortunately,
brave soul.
Yeah. You got to know what you're doing. But there are some fungi that grow on our body as well. And so can you speak to the fungus that can invade our shoes and our feet, tinea pedis, and then maybe onychomycosis and things like that? And what are there some new different treatments? Onychomycosis is a bear. It's really tough to get rid of.
Yeah.
What kind of approach would you talk about? So let's break it down. Onychomycosis, just like the fungus of the feet, an athlete's foot or tinea pedis, and kind of thickened, scaly, junky looking stuff, and cracks and bleeding and stuff on the feet. Very, very common. And onychomycosis is thickening of it's fungus that invades underneath the toenails and can thicken and grow. And we see this in like all age groups, actually. I see it in teenagers, runners, and football players, and but very, very commonly in like older people as well, diabetics and things like that as well. But let's speak to it. Onychomycosis, tinea pedis.
Yeah. Okay. Let's get into the nitty gritty. So, well, the interesting thing is I think there's fungus everywhere. It's everywhere. So people always go, oh, I think I got this from walking around barefoot somewhere, blah, 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 blah. Well, kind of. What really happens is some type of trauma either to that nail or to that skin that really can seed that fungus, especially for onychomycosis, which is that thickening of the nail, that yellow nail, the, uncomfortable nail. That usually comes from you were running in a shoe, you damaged that nail, the fungus seeded inside the toenail or got underneath it, and it starts to grow. And what's difficult about it is people are like, oh, I want to train, I want to cure this. How can I cure it? And it's not really in the body. It's growing on the body.
Yeah.
And so people are like, can I just take a medication and clear it out? And I wish that would be amazing, but it just doesn't work.
Yeah.
And so there's, topical remedies that can and cannot work depending on how good you are at using them. There's oral medications, and people think the oral medication is killing the fungus. It's really seeding in the toenail as it grows out. And so as the toenail is growing out, then it has a medicine in it, so the fungus can't grow in it. But you have to wait 9 months for a new toenail to grow in.
Yeah.
And so people get really frustrated. So that's like onychomycosis, especially if you're diabetic, you're just not very healthy. Your body doesn't fight infections well, doesn't fight fungus. So it has an easier chance of getting in there.
Yeah.
But one thing you should always notice, it's not always a fungus. It could just be trauma. It could be just trauma to that nail. And a lot of people come in, I have a fungal nail, and it's on one toenail and it's their longest toe and it's getting beat up in their shoe. That might just be trauma. So that's something to look for.
Yeah.
But then tinea pedis, athlete's foot, that you
let me pause you on the onychomycosis space. So are you removing these toenails and debulking all of them, or do you leave the toenail on and then treat and then?
Yeah.
Okay.
So I think it's a good one. I would love to remove the toenail and then treat it, because honestly, that's a great way to do it.
Yeah.
People don't want their toenail removed. And I get it. It's, they want their toenail there to paint it a lot of times, or they think it looks normal. I think the best way is you're removing that burden of bacteria or fungus, right?
Yeah.
Yeah. So if you get that away and then you treat it as the new nail grows in, you have a higher success of getting rid of it. People who don't want that, you're topically putting something on, hoping that it gets down under, killing that fungus. There are new things coming out. There's something called Swift. It's a microwave therapy. They treat it for warts, but they're starting to see positive things for fungus. So that's something that's out there.
Lasers, yes, no. I've seen a few of them. They claim to treat it. I think this is a really tough bug to kill. It's tough.
Yeah, and I think the hard part is does a laser treat it? Probably. Have I seen great results? Not personally.
Yeah.
So I don't want to say it's not a viable option, but I also do stuff that doesn't work too sometimes. And it works for some people. And so it's so hard. And I actually will biopsy most of them to confirm that it's actually a fungus.
Sure.
Because a lot of times it's not.
You get psoriasis down there.
It could be, psoriasis. Toenails and fingernails can look really funky for a lot of systemic diseases. So it could be due to a liver function issue. It could be due to, like you said, psoriasis or eczema. And so that might be it too, and not actually just a fungus.
Fungi really like warm, dark, moist areas. And that's your feet, that's your armpits, that's your groin. And these are common places for people who get fungal infections. Do you treat their shoes? How do you like to do that? Do you spray them out? Do you bleach their stuff? Do you take all their insoles? I don't know. What do you do?
I like that you think of it that way, because that's really smart. Personally, how I do it, so let's say you come in and you want just a topical remedy. So I actually treat it 3 ways. So I have a particular brand I use. I use a topical on your nail. I use a topical between your toes and on your feet, because if you have fungus on your nails, you have fungus on your feet.
Totally.
And then I use a spray for the shoes too. And I have them spray it before they put it on and after, and every shoe that they have.
Okay.
Because there's no point in putting your foot back into the land of the fungus.
Sandals and Crocs?
If they're good, I like Birkenstocks. I like Oki, if they have an arch in it, support.
But spray them all for sure.
Spray them. Yeah.
Me too.
Go for it. Yeah, just spray it. It's not going to hurt. It's going to just help.
Okay. Well,
socks, clean them. Just clean your socks.
Clean your socks.
Change your socks.
Is there like a OxyClean for antifungal? I mean, what are there? Bleach kills all fungi.
Yeah, I mean, if you bleach your socks, but a lot of people have these, nice socks nowadays that they gotta be careful, color stuff. If you're throwing them through the wash and everything, you're doing a high temperature wash and you're doing a warm to high temperature dry without damaging your clothes, it's fine.
Okay. Yeah. My socks all shrink into little midget socks. It's great. Tinea pedis, you mentioned that a little bit.
Yeah, I mean, that's another fungus of the skin.
Same stuff.
But, that's, if you're itching and burning on your feet, it's an easy fix. You can topically treat it with a cream and that usually will go away. Also treating the shoes, because there's no point in treating it and then putting your foot back into your shoe. Yeah. If it's bad enough, you can orally treat it. But usually, just a Lamisil over the counter will do a good job. And then if you're not having, results with that, then go see someone and, see if there's something stronger to do it.
Yeah. Good. Do you, while we're on topical feet stuff, let's talk about warts. Let's talk about plantar warts.
Yeah, let's do it.
And then let's go into bunions from there. And so speak to the plantar wart space. What do you guys like to do?
Yeah, those are awesome, right? No. So actually, I get a lot of referrals from dermatologists for plantar warts for a couple therapies, just because they're just a pain.
They're tough to treat.
And the reason is because your skin's thicker on the bottom of your feet. And so people who try to freeze them, it doesn't work, because that's typically, if it's on your hand or arm, you can freeze it. It works great. You try doing it on the bottom of your foot, it's just too thick of skin.
It's so
You're not going to get it. Yeah. And again, kind of what we were saying with fungus, a virus, it's not recognized by the body. Right. It's growing in your skin and just like leaching blood off of you, which, nice to know. Nice fill. But yeah, it's just hanging out there. So personally for me, we can try blistering agents with the whole idea of lifting that wart away from its blood supply. I find that very painful for the patient after. They're walking, they got a blister on the bottom of their foot. They're trying to play soccer or weekend warrior softball tournament. They don't want it. So I actually use a thing called Swift, which I mentioned earlier. It actually sends microwaves into the wart and causes the virus to shed the markers for the body to recognize it. And the body actually attacks the wart. So the Swift, I won't lie, it's painful getting it done, but after there's no blistering. So you can go onto a regular life and be happy. And it works for immunocompromised pregnant people, and you don't have to be worried.
That's pretty cool.
Yeah, it's a pretty cool thing.
Yeah, traditionally we will shave them down with like a 15 blade as close as you can until you hit the frog or the kind of, it starts to bleed a little, and then we'll spray them. And then every 2 weeks we got to spray. And then sometimes it still doesn't go away. Yeah. And then the topicals, they're like cantharones, cantharon pluses with the acids and stuff.
And I do that too, depending on if that's what the patient wants to try.
Sure.
And it does work. It just oftentimes it could take 6, 8, 10 treatments. And then if you have what's called mosaic warts, warts all over.
Yeah.
You don't want to treat every single one of those with an acid or something like, ouch.
Right. That's tough.
Yeah.
That's tough. Let's talk about bunions and calluses. We have a lot of athletes that we treat at the Voice clinics, and a lot of pickleball is very common. So people are getting lots of these, they're getting bigger calluses on their feet, maybe painful. And then what's the difference between a callus and a bunion?
Yeah, that's a great question, because people often come and say, hey, I have this massive bunion, and that's a callus, right?
Yeah.
So quick thing, bunions, skeletal, and a callus is dermatologic skin. So calluses, especially with athletes, you're having some type of trauma to an area on your foot, and your body's trying to protect itself. So it builds thicker skin. The problem is now you have thicker skin, it's getting more trauma, more pain, and you build more and more callus.
Yeah.
And so you'll see that on joints, you'll see it on heels, anywhere it's rubbing, your body can build a callus up. So that's that. And so there it's just protecting that area, whether it be trimming it down, whether it be putting on a lotion with urea in it, urea, over 40%. If you can get it, will really break down that callus.
That's different than the amlactin stuff.
It's like, so you can find a lot of stuff that's like 10%, 20%, but really if you're looking for something that's really going to break it down, if you use it daily, 35, 40% is key.
It's worth mentioning. I see a lot of people with very thickened heels and very thickened bottoms of their feet, and it's often cracked and scaly and almost can bleed. And there can be a co-infection of a fungal infection with that. And so with the urea process, I'd say make sure that you're seeing a healthcare professional to like, no, okay, that's not a fungal thing. That's actually a big old callus that we need to treat with one of these more aggressive topicals. Okay.
Well, and what's cool with that too is a lot of stuff in my office actually have both in it.
Oh, cool.
So they're antifungal and urea.
Smart, because it's probably
it's probably both. Yeah. Like I said earlier,
there's fungus everywhere.
Yeah,
100%. Yeah,
you go looking for it every weekend. So no, it's everywhere, and So for me in my office, everything I have is antifungal to some extent because it's just there.
Yeah,
and you don't want to get a deep-seated infection, a fungal infection, or a bacterial infection in those cracks. So that can be very painful, especially for the older patients.
So painful.
Yeah, diabetics, you can't. You're struggling with it, and
bunions.
Yeah,
break them down.
So there are two types of bunion: juvenile bunion, and then an acquired bunion. So juvenile, they're both the same bunion, but they come like a younger person gets a bunion, and it's because of their skeleton. There's a posterior tibial tendon, fibularis tendon. They're all kind of pulling at this joint, and it causes a turning of the bone. And so you get this big bump at your first knuckle on your foot. And people think it's a bone growth, but really it's just your bone coming out of position. And it can be very painful. There's a nerve that runs right over it. And so people can get like lightning, burning pain. The joint doesn't articulate. Meaning
that's on the medial side of the foot.
Yeah, medial side. Yeah. So as your big toe, the big joint, like if you look at your thumb where it meets the hand, it's the same thing on your foot.
I feel like I should bring my foot up here.
Yeah. Too bad we can't show it here, you know.
I am a foot model.
Okay. We got a foot model here, so he'll show it to us. We'll show pictures. So, you know, it's basically your bone is turning out, and then it doesn't articulate. So it's painful because it's not rubbing against each other how it should be. And so, you know, youth or older people can slowly develop these bunions, and they're very painful. But they can be solved. You can go conservatively. It's just padding them, you know, getting a wider toe box shoe, things like that, if that's what's bothering you. But if it gets to consistent pain, some type of surgery usually is what's needed to rotate that bone back in the proper position.
Man, and that's for younger kids.
Younger and older.
Oh,
yeah.
Really?
Yeah, it's to kind of do it for both.
Okay.
There's things you'll find online, you know, the bunion stretcher or things like that. Really, because it's such a bony skeletal deformity, you're not going to find anything strong enough that's going to keep it and pull it back. You really need to rotate the bone.
And it's going to be on the DIP joint, the distal joint that you're.
It's going to be your
or on the
metatarsal phalangeal joint. So yeah. So there's like two bones. If you ever look at a foot model, there's two little tiny bones called sesamoids underneath. Those get out of position. So you're really rotating those sesamoids back into position and then fixating it somehow. I personally do like what's called a minimally invasive surgery called a mini bunion. So I can do it through like a 2-centimeter incision, which is really cool.
That's cool.
And I put a plate up your shaft, 2 little screws in, and you can actually walk on it right after surgery in a boot. Traditionally, that's not the case, but there's a lot of really cool things now. So a lot of people get scared, like, oh no, I have to get a cast. I can't walk on it. That's kind of gone to the wayside. It still can happen if you have a really bad deformity, but most people, you can fix it really simply.
Difference between bunion and genu-varus.
Yeah, so that's kind of like a full foot deformity. Your varus, you're walking on the outside of your foot, or valgum, you're kind of like on the inside. It's technically for bunion called a hallux valgus deformity. So you're having an inturning of that toe, the valgum, I guess, valgus deformity rotation.
So it's more of the bones of the foot that are involved, not just those tendons.
Yeah.
Oh, cool.
Yeah. So,
but also surgery to fix that.
Yeah. When you start getting, when it's a full foot, if you're getting like a varus or valgum, so interning or outturning of the foot, you can try inserts or some type of like bracing for that to help it. But for the bone, for the bunion, you would most likely surgery.
I gotcha.
Yeah, or some type of padding.
And do you just wait until it starts getting so bad that they're like, okay, it's time?
Yeah, I mean, I tell people if they come in and they're like, hey, I have this bunion, it doesn't bother me, I'm fine. I say, don't do anything. You know, there's no point in doing surgery because once you cut it, you cut it.
Yeah.
And at least that's my model. I'm very sports medicine focused. Surgery's the last resort. But if they come in like, hey, this bothers me every day. I'm like, I can't wear shoes. I can't do this. I'm like, let's fix it.
Yeah.
Or it's starting to get there. Let's fix it.
Smart. That's smart. Okay, cool.
Yeah.
Other common foot things. I mean, I see a lot of plantar fasciitis. There's a couple schools of thoughts with this one. I mean, is it a foot strengthening process? Is it a foot stability process? Is it an arches process? And so I think probably a combo of all of the above. I had it really bad in residency. I was running up and down the stairs, really bad shoes, and I don't think I was supporting my feet enough and put on some weight because I'm eating all the food and cortisol levels are all time high. And,
And I weighed so much in residency.
It's stupid. Yeah, it's dumb. So I got it really bad, and it literally took me like a year to fix it. I had to get better shoes. I had to do some arch support. I had to do some foot strengthening. I kind of multi-pronged approached it.
Yeah.
But now I hear people saying it's not an arch support issue. It's more, strengthening your feet thing and walk, barefooted more and do all these things. And so I don't know. What's your thought process on plantar fasciitis?
Yeah, kind of all of the above there. Yeah, so plantar fasciitis, people, they focus on it because it's heel pain, right? They get out of bed in the morning and like, my heel's killing me. So they think the issue is solely the heel, or the patient does. What they don't realize is you have Achilles and your calf muscles that come down and attach to the back of your foot. And when those get tight and shorten, it starts to flatten that arch of your foot. And so you start getting micro tears in that plantar fascia, and that's where the plantar fascia comes from. So it's kind of a multi-pronged issue, like you said.
Involving even the gastroc, the calf muscle, tight calves, tight Achilles.
That's the primary issue.
Wow.
Yeah.
Oh, interesting.
So, because if you ever like look at a foot model and you can kind of put your hand up, you got your Achilles and it attaches. And if that gets tight, it flattens that arch.
You know, in teaching how to fix this, we always go through like a calf stretch, a calf roll. I have a fun little video on my YouTube channel about, plantar fasciitis and I never really connected like that is the actual inciting pathological problem is that tight Achilles tendon.
Yeah. And in fact, what I tell people first thing, where I give them a little pamphlet with 4 or 5 stretches and I have them hold it for at least a minute, not this 15-second thing. Hold it for a good minute, 4 times a day, all of these stretches. And if you have a mild case, it'll get rid of it because that's really where we're having the issue. The problem is you get down the road and you have so much inflammation and those micro tears in your plantar fascia that you need to do something more.
Totally.
But I would say if you're starting to get it, stretch those Achilles out, your calf muscles. You need a good shoe. I call it the taco test. So you can take your shoe and fold it in half and make a taco for Taco Tuesday. It's not doing diddly squat for you.
Yeah.
So you need something that you have that arch support. So if you're doing that, you're doing the stretching, you can ice it, over the counter, ibuprofen, things like that. If that's not helping you, then, you probably need something more, but that's a good start.
I talk to my clients about stability shoes and in this specific issue as well. And we do the taco and twist test. So we bend it in half and then twist it. And if you can twist your shoe into like a total pretzel, then it's not a
you're
good
not
shoe.
getting any support.
There's a ton of good shoes out there.
Yeah.
And they all make a stability line. So Brooks has one, Saucony, and all of them. New Balance has a great stability shoe. Solomon, Ultra. I mean, they all have a stability shoe. And the stability shoe is like the distal 2/3 or more is really stable. It doesn't twist. It doesn't move. It's got a really solid heel cup. And it doesn't like fold up like the taco way. Yeah. It folds at the toe a little bit.
Yeah, which is fine.
Everything else doesn't. That stability, you're saying like prevents that micro tearing of that plantar fascia, preventing that inflammation and really mitigating a lot of the pain. Do you ever do anything more drastic than that? I mean, people should maybe go get a stability shoe. And then is there a time where they like, okay, you got to like cast your foot or put it in a brace or something?
Yeah. So how I kind of treat my patients is I start off with the stretching, talking about good shoes. I start talking about maybe an over-the-counter insert or even a custom insert. Yeah. Because you put that in, it's fit right to their foot. It's supporting that arch, not allowing it to collapse with the tightness of the calf and preventing those micro tears, allowing it to heal. So that's kind of a beginning. And then after that, you get down to, are we putting a steroid in there? Are we doing a laser therapy to help it cure? Are we putting platelet-rich plasma in it? Some people will put people into like a night splint where they're like flexed all night. Personally, I couldn't sleep that way. If you can sleep that way, go for it. I'm not going to give you one of those braces, but if you get it, try it if you want. The next step after that would be you could theoretically put someone into a boot or cast them, right? And just let it heal. The problem is they're going to come out of that weekend and tight. Yeah. And so plantar fascia is going to probably jump right back. Physical therapy is another option. Let's say you do laser, you do PRP, you do steroid, you do the shoes, you do all that, you can actually do a surgery through a scope. You cut 2/3 of the plantar fascia. You walk out of the surgery center and you don't ever get it again.
Oh yeah, because your plantar fascia is done.
Yeah.
Does it serve a role of support? I mean, is there problems with doing that?
So you only cut 2/3 of it. Okay. So you still have that lateral. Usually it's the medial band that you're cutting on the inside of the foot. The outside of the foot you're leaving. So you're still getting that support. It scars in and kind of lengthens it. So typically you're still getting the support you need. Funny enough, sometimes people will come in with plantar fascia so bad and you're treating it, and then they'll come in and be like, "Hey doc, I felt this big like burst in my foot and I got this bruise, but I feel great." Yeah. They basically did their own surgery. Yeah. And they do great. I actually had one today. Yeah. Literally had a bruise on their foot and they're like, "Man, I'm doing great." I'm like, "Well, you probably did surgery. You're doing great." Yeah. Like, and not going to have an issue. So as long as you're not cutting the whole band, you still got that support.
I remember when I was suffering with this, I did an orthopedic surgery rotation and the orthopedic surgeon's like, "Oh, I had that one time. Let me tell you what I did." And he says, "I went out to the parking lot and the curb right there where you park your car." He's like, "I just stomped on it super hard."
Ouch.
And he tore his plantar fascia, and he's like, never had a problem. So
like he's never had a problem, I'm sure.
He's a total gangster. I don't recommend that.
I don't recommend that either.
You could damage some stuff.
Yeah, disclaimer, Dr. Hammond does not recommend pounding your foot.
Oh, and speaking of disclaimers, this is not medical advice, folks. This is just us talking shop and educating the community. If you have some foot and ankle problems, talk to your healthcare professional people. We'll help you navigate that. Yes. Okay, just had
that's funny. That's hilarious. Well, it's kind of like people who do like the Bible cyst, right?
Yeah,
they take a Bible and they smash the cyst, hoping to burst it.
Yeah.
Ouch.
So I love that. I really like what you said about some of the other adjuncts. You know, the PRP stuff and the steroid stuff. I did have a steroid shot during my and I don't know. I think before docs do these procedures on people, we should have them done to us.
Yes.
A lot of our procedures, because that's painful as hell. Like that was so painful.
I have a question for you. Did they go from directly into it or did they go from the side?
I think they went direct in.
Yeah. So
painful.
Shame on them.
Okay.
Those needles are long. Just go through the side.
Oh, that makes
sense.
Not
painful.
That makes sense.
As a shot, but yeah, I never poke people in the bottom of the foot unless I absolutely have to. Because like numbing the foot, there's a big nerve that you can hit in the soft spot and it numbs the whole bottom of the foot. So there's no reason to jab someone in the bottom. So I'm sorry.
Rookie error.
Well, rookie error, old school.
Dude, his Navy doc, he's like, I got this. Yeah. We do this all the time. I trained at a Navy. Okay. All of my attendings were Navy docs. Okay. It was in Jackson.
Yeah.
They don't care about you and your pain.
No, I saw doctors do that and I cringed. Yeah.
Let's talk about stress fractures.
Please.
Most common spot, a stress fracture in the foot.
Yeah. So I call it kind of the quarter region. So on top of your foot, kind of over your fifth, fourth, and third knuckles, kind of inside on top of the foot, there's that region.
Yep.
That's kind of where we see them most of the time.
Yeah. Lateral kind of.
Yeah. Lateral proximal. Outside of that foot, lateral proximal of the metatarsal heads is, you're going to see 90%, I feel like, of your stress fractures there.
How do we avoid them? Is it the running style? Is it the quantity, quality? What is it?
Yeah, I mean, so if you look into like research and what it says about it, in fact, I was just reading a bunch about it, and they say it's people who go from, they have a high increase of some type of activity.
Yeah.
So whether you're coming from the couch and going and all of a sudden running 3 miles, or you're going from 5 miles and all of a sudden you're running 15 miles really quick, you're building up really fast. If you do that too quick and you're in horseshoe gear, typically, or maybe running weird, I don't know what weird is, but you're running different than what you're used to, you can stress those out. You can really avoid that by slowly increasing.
Okay.
Yeah, that's really the big thing, is just taking your time and getting up there. But really, if you're like a high athlete and you're exercising every single day and you're putting a lot of stress on those bones, you're still prone to that potential stress reaction.
Another thing I see a lot is these calcaneus heel spurs, these bone prominence coming right off the calcaneus there, or that's your heel.
Yeah.
What are we talking about there?
So you like talking like underneath where like the plantar fascia inserts? Yeah. So you'll see a lot of those where like the plantar fascia is being pulled on it and pulling that spur.
And then creating it?
And creating it.
Sure.
It was like, what is it? Davis's law? Like if there's a reaction or something against it, it will form something. And so you're pulling the bone and the bone's kind of like under stress. It will form bone and kind of pull it. And you'll see it with your Achilles tendon too.
Yeah, there's a similar phenomenon in muscle. Like we used to see like the linemen for football and stuff. They'd get these myositis ossificans where you get like bone forming in your muscle because you're just hammering it so much. So is it from like tightened Achilles and then trauma to the area causing inflammation and then calcification after that?
Like it's usually that you're having some type of pulling sensation. So whether it's from your plantar fasciitis or your Achilles causing tension, you'll see spurring in the Achilles the same way going up. We call it like a candlewick sign or something. You're seeing it looks like wax kind of going up the bone. Sometimes those can be symptomatic. A lot of times the ones on the bottom of the foot, they're incidental findings. You'll take an x-ray and there'll be this big spur and they're like, oh, you have a big spur. Probably not causing any issues.
Yeah, sure.
Yeah.
Sure.
You'll see it when it's infecting a joint from like moving. That's when it usually becomes really painful or symptomatic. But on the bottom of the foot, I don't remove bone spurs down there unless there's a really like it's broken off and you can tell that's the reason. Usually it's the tendon or the fascia that's causing the pain down there, but it's not the bone spur.
Got it.
Yeah.
I've seen a couple of these get shaved down. I'd like to dive into heel striking just a little bit. So is heel striking a possible etiology for a bone spur that's not off of that plantar fascia or that tendon? I play a lot of pickleball and have some other pickleball pros, and there's a lot of hustling to the kitchen line and then a sudden stop, and there's some heel involved there, and then a lot of side to side with hopefully more midsole to toe movement, but then sometimes you do hit your heel, and there's a lot more stress on your feet in pickleball than the average sport probably. And so I guess heel striking, let's speak to it a little bit. I think overstriding during running or walking, folks tend to like just strike their heel more and creates problems at the knee, creates problems at the foot, creates problems at the back. So I teach a lot of my folks to just like shorten your strides and try to like midsole walk or even like toe walk for a while just to get out of that heel striking tendency. Do you have any thoughts on that?
I mean, biomechanically, like I'm not like a expert on like your running form, so I don't want to say, run on your forefoot or rear foot. Yeah. I mean, naturally walking, the natural gait is to do kind of a lateral heel strike and roll out to the big thing. But when it comes like pickleball and stuff, the ready position is to be up on that midfoot and on the forefoot there. And that's where you should be. You're not going to get that heel strike. Now, granted, you're going to go for a long hit hard, and that's fine. But you don't want to be consistently doing that. You don't want to be sitting back on your heels and running, especially downhill. You don't want to be trying to stop yourself by slapping that heel against the ground. So I would say avoid it, but it's not like something you have to, I think now if you're worried about it, to go think about it. But if you do have that heel pain, maybe that is something you need to go find someone who can help you train to be better at it.
Cool.
Yeah.
Speaking of pickleball, Achilles tendonitis and the slayer of giants, both pickleball and Achilles tendonitis and Achilles rupture are the slayers of giants. And so
well, in that pickleball rage, you start picking it up in your 30s, and that's right when you rupture that Achilles.
Totally. Yeah. I've seen it a bunch of times, and they start getting a little Achilles tendonitis, and then they keep playing pickleball because pickleball's so fun, and then they keep playing some more, and then they play some more, and then boom, and then it's a big 2x4 to the back of the calf, and it ruptures. What do we do to prevent it? And then, if it happens, what do we kind of do then?
Yeah. I mean, again, stretching is a good thing. If you're going out, you're playing pickleball, you're a weekend warrior or a consistent pickleball player, stretching before and after. I think a lot of times people are either doing one or the other, but really take that time to really loosen it up. But even the best athletes, look at Kobe Bryant. He went for a pick, bam, it ruptured. Now, I don't know if he was having issues before that, but it can happen to anybody at any time. So it's like, don't be like overly worried about it, I guess. But if you are having that pain in there, then it's time to start thinking of doing something, whether it's wearing some type of ankle brace or a brace sleeve to keep it warm and not get like cold and tight. Good shoe gear that you're not rolling your ankle where it has to do more work than it needs to. Because a lot of times, if you're stepping out, your ankle is starting to roll. So your Achilles, tightens up, trying to stop it, and it bursts. But then just doing other treatments. If you feel like you're really getting inflammation, going maybe a PRP injection, laser therapy, physical therapy, things like that. Don't ever get a steroid in your Achilles. Avoid that. So if a doctor says do that, because that can degrade and actually cause a rupture.
It makes it more brittle, right?
Yeah, it makes it more brittle. So really avoid that back in that region. Is what I would say. But yeah, I mean, if you're getting that pain, do something so you don't continue to like fight through it. And
do you have an opinion on Levaquin, ciprofloxacin, these fluoroquinolone antibiotics that could drive some fragility to some of these tendons and create tendinopathies and tendinoses? And
I've read about it.
Yeah.
I don't know if I have like a personal opinion about it. I wouldn't be on them long term. I think that's probably where you would see it. I guess if you were on one of those medications, maybe give it some time after whatever infection or whatever you're doing to let that go away.
I think docs used to be pretty cavalier with the ciprofloxacins and levofloxacins, and especially with like sinus infections. I mean, Levaquin was like, hey, let's just prescribe Levaquin. And now I think we're rolling back on that. There's some pretty good data that's showing that it's much more common, these tendinopathies post ciprofloxacin and levofloxacin. And so, I think we're rolling that back.
That's good. Yeah. I mean, I don't particularly actually use those medications very often unless there's other allergies. Yeah, I mean, it's there. I've read about it.
You don't treat UTIs? That's so weird.
Yeah, UTI, outside my range there, pneumonias. Yeah, maybe a cardiomyopathy I tried. No, but no, and typically the infections we see in the foot, we're doing Keflex or something a little more mild, or if it's really bad with that diabetic foot infection, they're going into the hospital and, that's a different story. So,
so we talked about like Achilles tendonitis. There's another really common one that we see, like posterior tibialis tendonitis. Anterior tibialis is like the dorsiflexor of the foot. So it raises the foot up, and it's that big muscle on the front of our leg. Tibialis posterior, tell us about it. Where's it at? And then where's that sneaky little tendon, and why does it get so fussy?
Yeah. Well, so one thing with the anterior tibialis, it pulls up, but it's also the primary slowing down of your foot. So that's where shin splints comes into play.
Yeah.
So that's an interesting thing. But the anterior tibialis and the posterior tibialis kind of work together. Posterior tibialis is more on the inside of your leg. It's that big muscle, and it comes right around that big bump, the ankle, the medial malleolus. And it actually, what we would say, supinates or scoops that foot up, is kind of turning that foot up. And it also helps dorsiflex as well with the anterior tibialis. But we see a lot of, tendonitis in that because the arch gets weak or they're in bad shoes. Again, shoes, having some good support there, because if it's constantly being stressed, that's where it gets inflamed. Another interesting thing we often see, where that tendon actually attaches on the foot, we can get an accessory bone or an extra bone, an accessory navicular. And sometimes people have a bone in there that needs to actually either be removed or supported somehow, and is weakening that tendon as well, which is kind of cool.
I've seen that. My buddy in high school had an accessory navicular.
Yeah.
Yeah.
Yeah. Well, I have a professional runner I'm working with, and she ran all through college, had this accessory navicular. They put a steroid there, which is not good. Don't do that. But could not get it better. I gave her some support. We did some laser therapy, and just supporting that little bone, her pain went away.
Yeah.
It really is just support. Is amazing what it will do for you.
Okay, foot model coming in hot.
Okay, let's see this. Okay, we got a beautiful
posterior,
foot up here.
Yeah. So tibialis posterior kind of runs down through here, and it can get really fussy. And you mentioned like if this arch starts to drop or whatever, that can drive that.
Yeah, because so that tendon's coming right around that bump, and it attaches right up in here at the height of your arch, kind of the keystone. So if you're supporting it, when you hit all that weight, it's not going flat. Yeah. Essentially, you're supporting it, so it's going to take tension away. The other cool thing is it's going to make you run farther and not get tired as quick if you're giving good support.
So arch support, yay on this?
Totally. Okay. Yeah. Right, you want it. Yeah.
More support, better shoes. If you're wearing crappy shoes, you can kind of exacerbate it.
Exacerbate it. Yeah.
Okay.
Yeah. I mean, honestly, for that and plantar fasciitis, good support there is going to it's like putting a brace on essentially.
Yeah.
Yeah.
We do some foot sole stuff for our clients sometimes, and we'll do like, a lot of them are just like a decent one from the running store. And probably 80 to 90% of the time we have reasonable results with that. Is there a time when we should consider a fancier arch support, that kind of thing?
Yeah. No, I'm actually a big proponent over the counter. I think for a lot of people, it's really great. Yeah. I personally use Pedis. They have actually a line where they have a high arch, mid arch, and a low arch. So you're kind of getting a semi-custom, right? Because you're looking at the arch. But yeah, oftentimes that does really well. But when you're getting where it's just like you're not getting better, then it's time to look at something more custom. And when you're looking at customs, do your homework. There's old customs and there's new customs. And the new customs are amazing. Personally, I make mine in my office in 15 to 20 minutes. We make the mold there. You're weight bearing while the mold is being applied to you. So that way you're actually getting your natural foot shape in the weight bearing process, and you walk out of them feeling great. Or getting casted, if you get casted, making sure they do a good cast. And it's hard for you to go out as someone who doesn't know what's being done, but that's something you want to look at. But yeah, a custom is really good, especially if you're a chronic plantar fasciitis, posterior tibial, Achilles tendonitis, you're struggling with that. That's the time to really start looking into it.
Okay. Awesome. That's super good.
Yeah.
Foot strengthening regimens. Is there like a video out there that we can just like see what's the best way to strengthen those feet and help them support themselves in some of these situations?
Yeah. I mean, well, it's hard with the foot because really the things that are really supporting that foot are all in your legs. Those tendons are coming down. You have a lot of muscles in your foot, but they're really tiny. They're doing very minute things. They're not really holding the arch up too much. So really for me personally, it's doing, squats, doing stability squats, standing on a Bosu ball and trying to do a lunge or on it to give that stability. That will help a lot strengthening. There are things out there, all over social media, online to strengthen your feet, and it doesn't hurt. Yeah. You're not going to hurt yourself trying to strengthen anything, I
like that approach. Yeah. I think it's more functional. I see a lot of foot drills like grab a towel with your toes and things like that. And those are kind of those little baby muscles, but more often you're going to put a lot of strain on your feet from the dynamic movement and having to stabilize. And so I like some of those.
Yeah, and grabbing a towel is great. I mean, that's a good one to really just kind of warm those muscles up. And it's not like you're going to bulk up. Like, it's not like your foot's going to all of a sudden be, Arnold Schwarzenegger, locking it in, putting the self-tan on there, showing off, like things like that. No. So like doing stuff like that's good, especially if you have like arthritis and things, moving that joint manually with your hand, whatever joint's sore, doing that's good. But really, you have two peroneal tendons coming down there, the fibularis brevis, fibularis longus, peroneal, the same ones, Achilles tendon, your posterior tibial tendon, your flexor hallucis longus, all those start up on your leg, your lower leg. And so really stability in that ankle and strengthening those muscles will help your foot.
That's cool.
Yeah.
I grew up really rural in a small town in Nevada, mining community. We had like dirt roads and there was no stoplights. But I was always in the mountains hiking and messing around and hunting and things. And just having that uneven surface, like constantly on my feet and ankles, like I never had an ankle sprain. Yeah. I was like super strong feet, super strong ankles, never had any problems till residency when I wasn't doing that.
You weren't doing that.
I was in
you
Florida, Flatland, Florida. And
you're walking flat.
Walking with bad flip-flops all the time.
Yeah. And you see that a lot with people who transition from road marathons to ultras or trail running. All of a sudden they're rolling their ankles or they're having ankle pain or ankle soreness. And it's just they're weak. Your ligaments are, not that they're muscles, but they need to be strengthened. There's proprioception in those ligaments that help you be stable. So training yourself to be, not stable. You're standing on a ball, your instability's there. You're standing on one leg, stretching, trying those things will really make you a better, especially as you age.
So this is a plug for mushroom foraging, because if you're foraging for mushrooms in the mountains, you're on uneven surfaces, and we're finding cool mushrooms that are yummy and delicious, and we're strengthening our feet and ankles.
It's a double. Now I want to know, do you have a pig going with you to find these?
No, I need to get one. My wife says no. She won't let me have a dog.
They're intelligent animals.
I know.
They're smarter than dogs.
I know.
Apparently.
It's ridiculous. Well, I'll let you chat with her. I'll give you
I'll call her later on.
Hey, give this guy a pig.
I don't want one, but he wants one.
Speaking of hiking, blisters are really common.
Yes.
There's lots of people hiking these timps and these big hikes and, rim to rim, Grand Canyon stuff. Let's talk about what shoes that you like. How broken in should they be before we embark in a hike? I had a guy not breaking his shoes and ran like a marathon or something. Dude, no. And then let's talk about blisters. So go with that.
Yeah. So, I love hiking. I hiked Kilimanjaro in Africa a couple summers ago.
Rad.
I want to hike Everest, but my wife won't let me.
Yeah. It's really sketch, dog. Don't do that. You can hike Mount Everest locally. So there's have you heard of these
Everest
people?
Ridge on
they do the thing and they just keep hiking it.
Yeah, they go back and forth. Yeah.
Okay, I hiked Everest.
Yeah. It's not the same. It's not the same. Weird. Anyways, no, I love hiking. And really with shoe gear there, a high ankle shoe is really good. Not a low cut ankle boot. But if you're trail running, that's a different story there. But if you're going on a hike, you're going up and down, it's good to have a high top boot there. If you're trail running, you don't always want that. You want a little more mobility, but making sure it's got a really thick sole on it to prevent from you stepping on a sharp rock or something, and it's got good laces. But naturally you're going to get blisters. And that's where you come into, what do you do with a blister? Do you pop it? Do you leave it? What do you do?
Okay, what do we do with the blister?
You pop it.
Okay.
You don't take the skin off, though.
Is it just for satisfaction purposes? Just because
Dr. Pimple Popper, plug for her. Don't know her, but there you go. No, so what you do is you just take a pair of your nail nippers, make sure they're clean, or something a little bit sharp, like a nail, and not a nail, like a safety pin, clean it off with some alcohol. Pop the lowest end where it's going to drain, let all that fluid kind of drain out. It's kind of a yellowish clear fluid.
Yeah.
And then leave the skin on it, and it acts like a Band-Aid.
Yeah.
And then it will dry off, and then you can trim it off or have someone trim it off for you, and you're good to go. And put a Band-Aid over it, moleskin after you pop it, because it's still going to be raw and sore.
Yeah.
But yeah, pop it, because it's just going to get worse, and it's going to be more painful because it's going to take up space.
I've got a pearl.
Okay.
So if you're starting to have some of those little pressure and you're on a hike, everybody should carry a little baby roll of what's called leukotape.
Yeah.
It's money, and it's not as thick and kind of moleskin. Moleskin works okay, but it's not. Yeah. It doesn't stay on very well. Leukotape. Don't get the stretchy leukotape. I think it's stretchy. It's the leukotape L or something. It's the one that's not stretchy.
Yeah.
And man, I have made through many pickleball tournaments with leukotape, saving my blisters from forming.
Yeah.
Because that you feel it, you're like, dang it, that's going to form a blister. Just put a surface of leukotape over that, and it provides that.
There's so many good things. Yeah, like
what else do you like? Yeah,
I like. You can get I just went blank in my head. So they're friction. So like friction rolls, it's like puts a thin gel on it to help. Similar things. I actually sell like a very thin. I don't know. It's probably like leukotape. I don't know what leukotape is. I'm going to go buy a pair. I'm going to go buy some today. But it's very similar. It's actually a silicone that you can stick right on, and you can actually reuse it.
Oh, cool.
And it fits in like your toes and your heels and all that. So yeah, just anything to prevent that rubbing, that friction.
I will say, if you put leukotape on your foot, leave it there for a few days, because that junk does not come off. And if you tear it off, if it's already starting to blister, it'll like tear off all this.
Well, I got to show you this cool silicone pads that we have, because you can take it off and then put it right back on when your next tournament. But yeah, and again, dry feet. So change your socks. So if you're in a pickle tournament all day long, every tournament, man, get a nice pair of socks, change it out. Maybe have a second pair of shoes that you alternate.
Yep.
One thing you did mention, breaking in shoes, right? Yeah. So I think you should break in shoes and you shouldn't break in shoes. Like if you get a good pair of shoes that fit you, you really shouldn't have to break them in. They should fit you and do well. Now, should you buy a pair of shoes and go run 26 miles? Yeah, I don't know if that's probably appropriate, but can you go in and go run a 5K? Yeah, that's fine.
Sure.
If you're going to go on a small hike, great. That's a good way to break it in. But yeah, if you buy a pair of shoes and they feel uncomfortable, they might get a little more comfortable with breaking in, but they're probably not the right shoe for you. So really, you should be able to put that shoe on and smile and be like, wow, this feels great. And, get properly measured, measure your width, get something that's nice and wide and comfortable for you.
Awesome.
Yeah.
Many of our listeners know that we at Voyage Clinics are a direct primary care practice. We have like an affordable membership model where folks can come in and get seen as much as they want. No copays, no deductibles. Most of our clients have insurance, but they don't use it at our clinic. We just see them as much as they want. They can telehealth and text whenever. And it's really beautiful care. You're doing something similar. I want you to tell our audience about it. It's a direct specialty care, direct podiatry care office, where you're not really doing much with insurance, but you're doing things differently. And how does that, tell us the name of your practice and kind of how that model has enhanced your ability to care for people?
Yeah. So, my clinic's easy. Hammond, foot and ankle. Pretty self-explanatory what it is. Dr. Hammond, there you go. That's
foot and ankle.
That's me. But yeah, so I'm a direct care provider.
Yeah.
Don't do any insurance. Don't bill insurance. Don't do any of that. And the reason why
is because you're a jerk, right? You just hate
I just want people to pay out the nose. I want to take all their money. Me and my fancy Mazda, we're just cruising down the road. Super nice Mazda out there. No. Honestly, you provide better care, I think. And what I was seeing is oftentimes doctors, and I think this subconsciously, they don't know they're doing this, but they start going towards things that pay more insurance, but might not be the best care. And I don't think they're purposely doing it, but I think it gets in their mind sometimes. I like it because you can come in and I can be like, hey, this is the best treatment for you. And we don't have to do what insurance would have to have you do before we could even try this. Because oftentimes insurance says, hey, you have to do A, B, C, D, E, F, G before you can try H. Well, I come in and so I know it's not going to work. Let's just go to H. Now, if they come in and say A, B, and C works, then we do A, B, and C. But I like it because it gives me better care for that patient. I see less patients. I'm not trying to see 40 patients a day. My appointments are 45 minutes long for your first appointment, which most doctors, they go in, it's like 5 minutes. Hey, you need surgery and jump out. And then the patient's sitting there going like, what? So that's what I really like. I do create a super bill which has all the codes and everything that you can submit to your insurance as an out-of-pocket. You can use your health savings accounts, flex spending accounts.
So super bills, often insurance companies will cover 80% of whatever fees just because they're out of network type thing. And so that's kind of nice to just, they can recover some of that. They can recover
if they feel like they need it.
Want to. Yeah.
I often find that patients who come in to my clinic that are kind of worried about that insurance, monster not being able to do it. They want to go somewhere. They leave going, oh no, direct care is the way to go. They actually leave happier because they realize they're paying for what they're getting. Yeah. And I think a good example is like a walking boot someone's wearing. Insurance sets a price for that boot. And so the doctor who's taking that insurance has to charge that amount or they get in trouble with Medicaid laws and all this stuff. So for me, I don't have to follow those rules. And so I charge you what's appropriate for the boot, which is usually half of what that boot is.
Yeah.
And so it's not cheaper in the sense that you're paying right away. It seems like it's not cheaper, but a week later when you get the bill from the insurance company, it becomes cheaper.
Totally.
Half or a third cheaper.
No, totally. Yeah. And it's interesting. So I did direct primary care 7 years ago. I'm a family doc, and I just noticed people getting pushed away from me from insurance companies, co-pays, deductibles, confusion, cost, care. And so I switched it up, and it's like you, I love to spend time with my people. I like to get to know them. I like to spend time with them and really provide good care to them. And that's my core value. Yeah. And I felt like it was being compromised on the system. And so kudos to you, man. We're the same. We spend 30 to 60 minutes with our clients, and we love on them, and we get to know them.
They have my cell phone number.
Yeah. We
go, they're selling a birthday. We sneak away and go grab a milkshake for them. We do little, it's just fun to get to actually know your patient, right? Yep. Know they're going on vacations, know their family. It's awesome.
It's beautiful.
It's really fun.
Well, good for you, man. Hammond, Foot and Ankle.
Yeah.
And you're in the Provo area.
Yeah.
Cool. And you probably serve most all of Utah County and down south.
I serve all Utah County. A lot of stuff that is not actually done. I see people from Salt Lake, Park City. I had people coming from Colorado. Yeah. Just because I do stuff that people don't do because of insurance.
Yeah. Dr. Hammond, thanks for joining me today.
Thank you. It was awesome. This is fun.
Yeah, I'm looking forward to. I just appreciate you sharing your knowledge and wisdom in the foot and ankle space. And as always, our objective is just to help people learn and grow. And thanks for coming.
Next week is pig foraging for mushrooms out in the wild.
I think we're getting towards the end of mushroom foraging season.
Dang.
I'll probably sneak up one more time this weekend to see if there's anything still out.
Sounds good.
Thanks again for joining me.
Thank y'all.
Okay, thanks, guys.